how easy is it for transitions of care for oral anticoagulants? So warfarin is difficult. So if you have a patient that's currently admitted to the hospital, their INR is not therapeutic or maybe super therapeutic or in that transition, we have to coordinate ambulatory follow-up for a recurrent blood test on the ambulatory side, whether it be for the patient to go to a reference lab, whether the patient has the home blood clotting time machine, whether we send a visiting nurse or a traveling lab into the patient's home. That all has to be coordinated with warfarin. And then also the doses. So we have to have a clinician that's assessing the doses and the dose titration of warfarin. With the direct-acting oral anticoagulants, the transition of care is very easy as the dosing is specific. So we can dose the patient. We do not have to schedule the patient for any follow-up monitoring acutely. We need to assess the patient after discharge, but the essentially transition for the patients on the direct-acting oral anticoagulants is very easy. How do we avoid any issues or prevent adverse events or prevent complications, unwanted complications for patients' disease when discharged from an acute facility or in any transition, so from an acute facility to home, acute facility to nursing home, home to a nursing home to home, any of those transitions. We, number one, need to educate the patient or the patient's caregiver on the purpose of the anticoagulant, why we're anticoagulating the patient, the side effects, drug-drug interactions, and the importance of taking the medication every day as instructed or twice a day as instructed, depending on the agent of use, to prevent the unwanted side effects of if we don't anticoagulate a patient. So patient education, number one. Secondarily is we have to assess the patient. Do we educate the patient once, or do we have somebody outreach to the patient for follow-up? So for instance, in transitions of care within 24, 36, 72 hours of a transition, do we have a clinician reach out to a patient or someone that's part of the care team to make sure the patient understands why they're taking the medication? Or number one, do they have the medication? So have they filled the medication in that transition? Maybe they have, maybe they haven't. If they haven't, understand why they haven't, if it's an affordability issue. If they had travel to the pharmacy may be difficult. There are multiple parameters that we have to take into consideration for why they would have the medication. Then assess, make sure they're taking it at an appropriate time, and understand what they should do if they miss a dose. And make sure they do have a follow-up appointment scheduled with their clinician somewhere in a week to 2 weeks of that transitions of care. So who decides or who should make sure the patient's being followed? Institutions, healthcare organizations should have protocols for appropriate parameter timing after transitions of care. So that follow-up phone call should be a standard process of care. It does not have to be a clinician. It can be someone that's part of the multidisciplinary care team, a nurse, a pharmacist, a secretary, someone reaching out to the patient to make sure they understand. If the individual reaching out to the patient is discussing with the patient and has an issue that they do not understand, they should have support and to increase the acuity back to the patient to make sure the patient gets the information that's needed, or a new prescription, and also education for the medication.